Hello, and welcome to Essentials of Monitoring, putting it all together. This is Alan Schwartz, DDS-CRNA, and the idea of this course is for you to look at all these slides. They should look very familiar to you. You should be familiar with them, and they're the most important concepts from your course. Of course, I want you to know as much as you absolutely can, but this is your foundation for monitoring and taking care of a sedated patient. If you don't understand these slides and you still have questions on them, that is not a problem. I want you to talk to either your doctor that you're working with, talk to some of your coworkers, maybe they can help you with it, and then certainly we are able to help you also. Please feel free to text, email, or call Dr. Schwartz, and I'll be happy to make sure that you understand every one of these points. As in all of our lectures, we have a disclaimer, and the idea of the disclaimer is to tell you that this is the way that I practice. This is the way that I've learned over the years, and that there's other ways of doing things. There's other practitioners, textbooks, lectures, journal articles, and I refer you to those if you have any question. So our first concept is how many people should support the sedated patient during dental surgery, and that number is 3. And depending on your state rules, 3 people need to be with the sedated patient in the room and support that patient. And those personnel can be the physician anesthesia provider, 2 dental assistants, a physician anesthesiologist, a dental anesthesiologist, and a certified registered nurse anesthetist, or also called now a certified registered nurse anesthesiologist. And of course, the sedation dentist counts as one of the people that can be in the room. So what kinds of patients are you going to be working with that are going to need sedation? They're going to be fearful patients, anxious patients. They're going to need long procedures, so a lot of work can be accomplished in an appointment or a long visit. Sometimes it's even a short procedure. I've anesthetized a person before with deep sedation for an alginate impression because they were such a severe gagger. And of course, we had to go through all the processes of making sure that they were NPO, that they had followed the rules. We still do the same paperwork, the same workup on them before we go ahead and get them off to their level of sedation. They can be used for painful procedures and invasive procedures, that is sedation dentistry. So let's talk about the continuum of depth of sedation. This is going to be one of the most important concepts for you because a patient slides from one, starting on the left, all the way to the right through the different levels of sedation. There's no start or stop point. They just slide through those and they can go into that quickly. And you need to be able to rescue a patient from one step beyond where your dentist has their sedation permit. In other words, if they have a minimal sedation permit, you should be able to rescue them for a moderate sedation and get them back to the minimal level. If your dentist has a moderate sedation level, which is also called conscious sedation, you should all be able to monitor them and keep them safe and have them get down to a moderate sedation level from a deep sedation general anesthesia level. Usually deep sedation and general anesthesia are pretty much lumped together, but there's different characteristics of each, and we're going to go through that in just a little bit. So just to review, a continuum is a continuous extent. Notice that from the previous slide, the arrow went from the left to the right. It's a succession or whole, no part of which can be distinguished from neighboring parts. In other words, there's no, as we said, start or stop point, and there's no arbitrary division. It's just some characteristics that you see in the sedation level for the patient. Let's talk about minimal sedation, also called the old name anxiolysis. So with this level, there's no depressed level of consciousness whatsoever. The patient can respond to you, they can talk to you, they can turn, they can swallow, they can breathe, they can move. So there's nothing that's depressed there for them through the sedation level. They can continuously maintain their airway and breathe on their own. So they breathe spontaneously and they can respond to any and all physical and verbal commands. So this state can be produced by pharmacological means, in other words, certain medications, and or non-pharmacological means like hypnosis, yoga, meditation levels. So they can be brought to that level depending on their training and their expertise, they being the patient. And the patient maintains normal cardiovascular function. So their heart rate and their blood pressure remain normal in their homeostatic level, I should say. As we get into the deeper levels along the continuum, we're going to lose these things because we're going to be taking them away with the meds that we're going to be giving the patient. Let's look now at modern sedation analgesia. This, again, is a minimally depressed level of consciousness. The patient can maintain their own airway and breathe spontaneously. They can respond to light touch. You can touch them on their face or their forehead or their shoulder and have verbal commands they'll be able to respond to. But they're just a little bit less alert in this level. So this state can also be produced by pharmacological and or non-pharmacological means, and the patient still maintains their normal cardiovascular function. This level of sedation is also called conscious sedation, and conscious sedation really is an old-fashioned term. And there's two ways that we can deliver moderate sedation or conscious sedation, if you will, to a patient. And those are the enteral route. Notice that I've got the words in brown because it involves the gut going all the way from the mouth all the way to the south end of the patient, if you will. And then there's the parenteral route or parenteral route of moderate sedation, in which we totally avoid the gastrointestinal tract, which is the enteral route. So the enteral route involving the GI tract is swallowing a pill. It can be absorbed from the oral mucosa in the sublingual or from the rectal side. There's drugs like chlorpromazine, which is a suppository for patients that have just intractable nausea and vomiting. So it can be given rectal along with rectal Tylenol suppositories and those sorts of things. So, what are the advantages of involving the GI tract? Why do we still do this to this day? Well, first of all, it's inexpensive. You don't need any IV equipment, no sets to plug in an IV, so an administration set, IV bags, tubing, syringes, needles, medications. So it's really inexpensive to do. It's like, here, swallow this pill. Or, hey, we can put this on your skin or something on that order. It's just very easy to do. And it doesn't require sterile technique. But there are disadvantages in involving the GI tract. It's less reliable dosing because you have the stomach where this pill was swallowed. The liver is constantly guarding over whatever is in the bloodstream in the system, and it's going to metabolize it very quickly. And that is called the first pass effect. In other words, when it's first passed, the liver says this is a toxin, even though it could be a Versed molecule, it could be a halcyon or a triazolam molecule. The body looks at it. And then there's the intestines that get involved. And when someone is anxious, they're not digesting food. Their parasympathetic nervous system is not kicking in. So they're going to get an unreliable dose. So if we gave 0.5 milligram, we don't know how much is in the bloodstream. So it can have a slow onset. It's less reliable dosing. We don't know exactly what the patient's getting. Therefore, it can be unpredictable. And there's not a secure route to the patient for an emergent situation, giving such drugs as phenylephrine, epinephrine, or ephedrine. Let's look now at the parenteral route. The parenteral route also uses and is considered being the sublingual, intravenous, intramuscular, which is going to be almost as fast as the IV route getting drugs to a patient. There's intranasal, in which we atomize spray and shoot that atomized mist up into the nose. We can give such drugs as Versed, ketamine. There's Covinase, which is a local anesthetic that can be given that way. There's the subcutaneous route. That's quite important nowadays. And then there's the intraosseous route. We're going to see that in just a little bit. There's the pulmonary route, and you're already familiar with that. We give nitrous oxide that way. And in the operating room, we give potent inhaled agents, one of them being sevoflurane, to keep the patient in a state of general anesthesia. For the transdermal route, it's become very popular. A lot of drugs can be now given this way, and some really innovative things are given this. I just want to show you that in a couple of seconds. There's fentanyl, and it has doses of 12.5 micrograms per hour. It can go to 25 and 50 micrograms per hour, depending on how the patient needs to be dosed. There's the lidocaine patch, and those can be given along the back or something on this order for back pain. There's EMLA cream that can be given to the IV site. So that's a mixture of lidocaine and prilocaine. And EMLA stands for eutectic mixture of local anesthetic. So what are the advantages of bypassing the gastrointestinal tract? As you could probably guess, I'm a real fan of this way of giving medications to a patient. First of all, it's going to be very quick onset. From the time we give it, we count what's called a circulatory time, or circ time, it's nicknamed, and that's the amount of time it takes to pass through the entire system to reach every cell in the body. It's going to be a reliable dosing, because if you're giving a dose IV or IO or intramuscular, there's a really, really good chance, unless the IV or something is broken or something along the line is broken, that they're going to get that full dose of that medication. So it's going to have rapid predictability. It's going to have really quick effects, so you can start to see things happen that you want to happen for the patient. And there's a secure route to the patient. You can see on the left here, I am giving fentanyl IV, and the picture on the right is me giving propofol through a pump to a patient. So it's going to be a secure route to the patient to get those drugs to the patient, those different meds we're giving them for their sedation. And I've got a route to be able to give the emergency medications where I didn't have that with the enteral route. So drugs like phenylephrine, ephedrine, and epinephrine can be given that way. But there are disadvantages to the parenteral route of administration of medications, and they are that there's going to be a greater expense to you and then for the patient to be able to have all the equipment and supplies and all the necessary armamentaria to be able to medicate the patient. It's going to be more invasive to the patient. We have to break skin if it's in the case of an IV or an IM or a subcutaneous. So sterile technique is required so that the patient doesn't get infected. And then again, there's that possibility of infection. Let's talk now about deep sedation and analgesia. Analgesia is again the relief of pain. This is a more depressed level of consciousness. The patient has a partial loss of their protective reflexes, and their protective reflexes can be such things as coughing, sneezing. If you come close to their eyelashes, the blink reflex, the withdrawal reflex when they're in pain, they're going to be blunted because of the medications we're giving the patient. They may not be able to maintain their airway, because a sedated tongue becomes very relaxed and it becomes huge. It's almost like a side of beef in the mouth, and it can block the airway. They may be able to respond purposefully to repeated stimulation, but maybe not verbal commands. So if I were to take a cow horn forceps and want to extract number 30 with it, and I didn't have local anesthetic there, the patient is going to respond to that. They still respond to pain. And this level is really only produced with pharmacological means. And the patient maintains their heart rate and blood pressure, so their normal cardiovascular function. Let's talk about general anesthesia. This is a controlled state of unconsciousness. There's partial or complete loss of their protective reflexes. They have the inability to independently and continuously maintain their airway. So we have to provide for an artificial airway for them, be it an oral airway, an LMA, an endotracheal tube, a King airway, because they're just not going to be breathing real well on their own under a state of general anesthesia. The medications may even knock out their breathing. They cannot respond purposefully to physical stimulation or verbal command, but their body will still feel pain. You still have to use local anesthesia. Even though their brain is medicinally or chemically asleep with an inhaled vapor or medications we give in the IV, their brain still senses pain, very, very much so. This is again produced by pharmacological means, and they may not maintain their normal cardiovascular function. When I've got a patient that I've just put off into a state of general anesthesia and they're prepared to have their surgery, if there's no stimulation to the patient, their blood pressure and their heart rate can really drop down low. And we've got to bump their blood pressure or their heart rate till they start their stimulation. And probably the most important point I can tell you is that amnesia is guaranteed and implied in this state. So realize this is the only state where it's guaranteed. So don't promise amnesia in any of the other levels. No amnesia guarantee for minimal, moderate, or deep sedation, only with general anesthesia. So let's talk about the parts of an anesthetic. And it's interesting because it's similar to, and it can be compared to an airplane flight. An airplane takes off. The distance between two different cities or two different airports is called cruise when you're in that stage of the flight. And notice that when an airplane takes off, the pilot doesn't just fix the wheel of the airplane and point it, say, from Minneapolis to St. Louis and then walk and have coffee and talk with the flight attendants. There's constant course corrections that have to be made while you're in cruise so that you end up at the correct distant location. And then there's the landing of the plane. So in anesthesia, there is induction, just like takeoff. Maintenance is the cruise phase, so this is where we have to apply meds to keep the patient homeostatic. In other words, their blood pressure, heart rate, their breathing, where they normally live. So there's corrections we have to make along the way. And that screen that's there that you see is called an ether screen, back from way back when in history when they used to use ether so that the surgeon didn't pass out. Of course, the anesthesia provider might have passed out or gotten sick, but that is still used to this day to maintain the sterile field. I digress, but we've talked about induction, maintenance, which is cruise, and then emergence, which is the landing of the plane. Let's talk about some paperwork. There's the health history. There's a separate consent for treatment for the patient's dental work. There's the anesthesia consent, which is totally separate. We used to use a source consent, so in case we had an accidental stick with a needle, we could get consent from the patient to draw some blood from them to see if they had such things as HIV. There's the post anesthesia instructions, and I give those to the patient while we're going through their consultation before they come in for their visit, because the patient is not going to be in learning mode when they come in that day. A lot of anxiety, they're going to be worried, their caregiver might be worried, and they're not learning. And then there's another form that we've developed that is called the Day of Surgery Assessment form. And just to let you know, all these forms are available If you go to sedationconsult.com, go to forms at the very top, and then all of our forms that I use in practice are there. So let's talk about these forms now. So with a health history, we've got to make sure that they fill in every blank and every line, and they check every box. Notice that this is broken down into the different systems of the body: the respiratory, lungs system, musculoskeletal, neurological, cardiovascular, liver, kidneys, and then others that don't fall into one of the other categories. And they can't just draw a line straight down all of them. They have to check each individual box. So if they do draw a line, say down all the nose, send them back, unfortunately, with the clipboard while you're doing this consultation, and make sure they chart the yeses and the nos. So leave nothing blank. I go through their post anesthesia patient recovery, their do's and don'ts with them. And this is a good time to do it while they're not in pain or maybe sedated or whatever. And then there's the day of surgery assessment form. This is a really important form to me. It's probably one of the most important forms that I use. It's going to give us a snapshot of what's going on with the patient's health history that day before we've started. You all are anesthesia people now, so make sure you fill in their patient name, the date, and this can be updated with another date. You can still use the same form. It should be done at least once a year. Allergies and medications are no known drug allergies. We want to know if they're allergic to any foods, especially soy or eggs, and that's because propofol is dissolved in either a soy or an egg base. But it turns out that the eggs that they're using are the yellows, so the yolks, and people are usually allergic to the whites of the eggs. And then you also want to see if there's allergy to any latex. We're not really using latex, but we're using nitrile gloves nowadays. And then you want to know if they've ever had trouble with anesthesia themselves. And some patients will say, I come up fighting, I come up nauseous, confused, it takes me a long time to wake up. And then I also like to know if any blood relatives have any problems. If we're using an inhaled agent, not nitrous, but sevoflurane or desflurane, if you're doing a general in your office, there's a thing called malignant hyperthermia, and that can really be a problem. So we want to know if any blood relatives have had trouble with anesthesia, and this is the place to catch that. Under social, we want to know how much ETOH or ethanol or alcohol that they drink. And after you ask them what they drink, you can pretty much, we were told in school, to double that amount. So if they're drinking a 6-pack or a 12-pack over the weekend of beer, you can pretty much double that. I've got to know if they're using any illicit drugs. I never report anybody. We don't do it for that reason. I want to know if they're using such drugs, especially cocaine and any of the stimulants, methamphetamine and amphetamine. And the reason is that those stimulants cause vasoconstriction, especially of their coronary arteries. So their arteries to their heart need to be wide open. There needs to be a ton of blood going to that heart tissue. So I would cancel a case. And if you've got a population where the people that you don't know or can't trust to give you an honest answer, then you can do a urine dip test to see all the different meds that are there. And then I want to know if there's tobacco use. And the main reason for that is for the person that's coughing, if they're going to cough during the procedure. I want to know if they're in pain, acute or chronic pain. I want them to tell me where it's located, and if it's on a scale from 0, which means no pain, to 10, which is, a lot of people will say, well, I'm not really, I'm in a 10 right now, my mouth hurts. And I say a 10 means you are about to pass out, or you've been going from consciousness to unconsciousness because it's so excruciating. Is that you? They'll give you a more honest answer that way on the scale of 0 to 10. LMP is the last menstrual period. I want to know if the patient's pregnant, if they're nursing. If they state that they're not pregnant, that's fine. I would circle each of those. You don't want to use benzodiazepines, and in other words, Valium, Versed, Triazolam, on a pregnant patient because the fetus can develop birth defects with that. I used to run pregnancy tests in the office, but I don't do that anymore. And if there's been a bilateral tubal ligation, a hysterectomy, which are sterilization procedures for the woman, or a vasectomy, or just abstention on their partner. So a recent URI is upper respiratory infection, not UTI, which is a urinary tract infection. If they've had a cold within the past about week or so, are you going to want to be creating vapors from the high speed and the water vapor that's put out so that all of you get to breathe that cold virus? I think not. And for a child that has had an infection, an upper respiratory infection, the rule of thumb, the way that we practice in anesthesia, is to wait at least 14 days to be able to treat the patient. Now, if they're in pain and there's an abscess, that's a different story. I would not probably use any sedation on them because they more than likely would need to be intubated if it gets to something in that order. I want to know if there's any chance of hiatal hernia or reflux. I don't ask them if they're obese. I'll just check the box. I will check if they've had their immunizations if it's a child, if they're immunosuppressed or taking steroids. That's going to be important to know. If they're in cancer, chemo, or radiation because of their healing, and if there's any anemia or bleeding disorders. I will have them, if possible, even though I know that they're NPO, I will have them swish with some water to clean the bacteria out of their mouth. And if I'm using medication like glycopyrrolate or atropine to dry their saliva, I want them to get their contacts out. And then I have them, the patient initial. This has got to be an adult patient or the patient's guardian if it's a child. I want to know they're telling me that they haven't had anything to eat or drink for the past 6 hours, that they've not smoked, vaped, or ingested any illicit substances. If they've smoked or vaped, will go about 2 hours for them for NPO. If they've injected or if they've ingested any drugs, we've got to find out what they are. Ingestion means at least 6 hours of NPO time. We'll go through that in just a bit. Someone else needs to drive them home no matter what. Usually we don't let them take an Uber or anything on that order. And then a responsible adult is going to be with them for at least the next 24 hours. The bottom half of the form is if they've taken their meds with a sip of water, I want to know what they took and what time they took it. Then I will observe and do a physical examination on the patient, look at their thyromental distance for their airway. I look at their neck range of motion. I listen to their lung sounds with a stethoscope and their heart sounds. Then to the right, you can see I record their NPO status for that day, their nothing by mouth, and I want to know their height and their weight. Then I have them open their mouth as wide as they can and stick out their tongue. And that will tell me their Mallampati classification, the MPC. Then we have to have a diagnosis for the patient of why we're doing the anesthesia that day. So you're going to have to either write in or circle one of these diagnoses that are there, like we're doing a crown, we've got loose teeth, we've got an infection, just whatever, poor repair. You've got to have a diagnosis. I look at their neck. I look to see if if they've got good range of motion, and circle if they've got a potentially difficult airway. I write in some remarks, and then we assign the patient a physical status. And we're going to go through that in just a bit. So we've got a diagnosis above where we said crowns, bridges, poor repair. Then we have to have a treatment plan. And there's MAC, which is monitored anesthesia care, which is IV sedation, patients still with us. They're able to respond. So this could be moderate sedation or even deep sedation. I've heard it called that for either of those levels. GETA is general endotracheal anesthesia. TIVA, it's actually pronounced TIVA, is total intravenous anesthesia. And then LOC is a local standby. That's where we hook up the monitors. A dental office isn't going to do this, and we observe the patient. We don't give any medications to them because they are so severely sick. They're going to be an ASA 4 or 5 patient. They're really sick. Then I check the box. We've discussed the anesthetic with the patient and any alternatives, and that all the consents are signed. Then I will sign that. At the end of the case, we write a post anesthetic note and then who the patient is discharged to. And if they're the caregiver or there might be another caregiver, we'll go ahead and list that there. So this is NPO status. This is the NPO guidelines. These came out in 2017. These are not hard and fast laws. They're rules that we follow in anesthesia and that you and your office needs to follow as a sedation dentist. So clear liquids, in other words, a liquid you hold up to the light and you can see light through, is 2 hours. Breast milk, we're not going to worry about too much, but formula, non-human milk, and a light meal. A light meal is defined as, say, some crackers or dry bread, maybe a hard-boiled egg, nothing with fat on it, no butter or anything like that, and some clear liquids is 6 hours to allow digestion to move the substances away from their stomach, away from their throat, so that they don't throw up and then possibly aspirate into their lungs, which means pulling nasty stomach contents down into their lungs, which you could possibly die from. If they've had a heavy meal, that is at least 8 hours. And that's just a normal meal. If you were to go to a restaurant, have butter, have rolls, have barbecued ribs, whatever, it's got to be 8 hours. Something new that's on the bottom of this NPO form is, again, if they've smoked, vaped marijuana, it's 1 to 2 hours they should be NPO. Anything ingested, I fib to you, it should be 8 hours. So that's considered 8 hours, not 6 hours, for someone that's ingested any substance. Let's talk about consent, consent, consent. We've got to get consent from the patient to be able to treat them, both for their dental treatment, so that's the treatment consent, the anesthesia consent, which is just going to be solely for the anesthetic, and then the source consent in case we have an accidental needle stick and we need to draw blood from the patient from a lab. There's a couple of concepts I want to go through with you, and one of them is assault. And it's the words assault and then battery are used wrong in the media. Assault is the threat of an action. So if I say, I'm going to punch you in the nose, that is, so I've touched the patient, but I said I was going to do this action to you. If I've threatened you or if I've informed you what I'm going to do, that's called assault. When I've touched you without your consent, without you saying, yeah, go for it, or signing your consents, that's called battery. And the dentist can be sued for assault and battery. That's why we have got to get consent for the patient. Let's talk now about ASA, which is the American Society of Anesthesiologists Physical Status Classification System. Every patient gets a physical status classification. And as we get bigger and larger in the numbers, it's going to be more and more difficult to treat that patient anesthetically. So, one is a normal, healthy patient. They're not taking any kind of medications, they're just normal and healthy. Two is a patient with mild systemic disease. So, this can be someone that, say, is missing part of their thyroid, or they might have low thyroid action and they're taking thyroid meds to keep them normal. Or it can be somebody with high blood pressure that's taking meds to bring them back to that homeostasis, that level where they normally live when they're healthy. 3 is a severely systemic disease. So this can be someone with severe breathing, blood pressure, heart problems. 4, their disease process is so severe that it's a constant threat to their life. 5 is a patient that is so sick that they're not expected to survive unless we get them into the surgery. 6 is a declared brain dead patient. And obviously, you're not going to be working on those in the dental office, but they have gotten a separate ASA physical status for that. So, depending on your level that your dentist has or that you have for your sedation, you're probably going to be working on ASA 1s and 2s. And make sure that you don't give somebody a 2 that is really a 3 patient, because if there's any complication, the board is going to look at that if there's any complications with the patient. So be honest with it and make sure that you're taking care of that. I have a deep sedation and general anesthesia permit, and I'm able to work on some ASA physical status 3 patients, but I won't touch a 4 or 5 in the office. There's just no way. And then there's the E class, which is emergency surgery. Again, you're not going to see that in the dental office, but if, say, somebody is a normal, healthy patient and they get into a severe car wreck, they might be healthy, but now they could have some severe problems internally. So they're given the status 1E. So let's identify the 5 critical patient vital signs. And they are blood pressure, respiration, temperature, pulse, and saturation pulsatile of oxygen. It used to be called, when I started anesthesia, S little a O2, meaning arterial, and they changed that to P, which I'm glad they did because you've got to have a pulse by the probe. There's some other vital signs that are considered critical that you should gather for the patient, and you saw on the pre-op form that we did that. One is height. You can see the father is on the left and the son is on the right. His name is Robert Wadlow, and obviously at 8'11", he's going to be treated a lot differently with his dosing and his airway and such as his father on the left. And then weight is also considered a vital sign. It just depends on the textbook. We should be dosing on body surface area, but that would mean that we'd have to send the patient to a lab to have them be dunked underwater to get their body surface area. So we use weight for that because it's pretty close to body surface area. And then don't forget to assess the patient's level of pain. I want to know where they're at on their pain level before we've even touched them, and I want to know where it is. If it's their lower back, I want to know ahead of time so that they can't say, well, I didn't have any back pain before I saw you at the office. So you said, no, that isn't true. You told me preoperatively you had back pain. Let's talk now about the physiology and the importance of the 5 critical patient vital signs. So make sure you understand these. Blood courses around our bodies in a circle. So oxygenated blood and nutrients and gases and such go to the patient and circulate to every cell. So that's through the arterial blood. And you can see that it's bright red. It's on the left there. And then there's deoxygenated blood, waste, and carbon dioxide that's put out by the cells. And they're pumped back along the circle, back to the heart, and then sent to the proper organs so that things are taken care of, like CO2 breathed out, or detoxification in the liver, or the making of urine in the kidneys, whatever. Each of the major organs, the lungs, the kidneys, the liver, and the brain, need a ton of blood supply to keep them alive. Especially the brain uses a lot of blood supply. It needs glucose, which is the fuel for the brain, brought to it constantly. But these are the major organs that command a big supply of our blood. That's why we've got to have homeostasis so that our heart is pumping blood to the patient, that there's enough pressure there to perfuse the tissues of each of these major organs. And don't forget, too, that the heart needs oxygen and it needs to have its waste products taken away. The heart receives blood during diastole. So when the heart is resting in that stage of filling up, that's when the heart's getting its fair share of the blood. So if a heart on certain patients is beating very, very fast, there's not enough time for the heart to fill up so that the blood can then reach each of the cells of the heart during diastole. So it just depends on the patient. Some people are trained and they're athletes, they're able to do that, younger patients, but some, like an older patient, are going to have trouble, and there's going to be a mismatch between there's just not enough blood pressure going through the coronary arteries to be able to pump that to the heart, especially itself. Let's talk about pulse. Pulse is the actual beating of the heart. I would know, and you need to know each of these waves and then what they mean. Each one of these waves represents something physiologically that's happening with the patient. Make sure you know this cold. Know what a P wave is. Notice it goes in alphabetical order. Then there's the QRS complex, so PQRS, and then there's the T wave. So let's look at some dysrhythmias of major concern. I want you to know what a normal rhythm is before we go on and you are able to look at and be able to recognize lethal rhythms or bad rhythms. Just know that the P wave starts in the sinus node. That's some tissue located by the right atrium. It sends its signal out to the left atrium simultaneously. That's what creates the P wave. Then the P wave goes down to the atrioventricular node, the AV node, down the bundle of His, and then it splits into a right and left bundle branch. And that's what creates the QRS complex. Notice how large the ventricle is compared to the atria, and that's why the QRS complex is so large, that big wave above there. Then there's the T wave, which is the repolarization. There's a sodium potassium pump that's pumping sodium into the extracellular fluid and potassium into the heart cell, the cardiac cell. And that's repolarization. For the ventricles, repolarization for the atria occurs during the QRS complex. So sinus rhythm is defined as a P before every QRS, and it's a rate, this is for adults, not for children, of 60 to 100 beats per minute. Sinus tachycardia, whenever you see sinus, that means there's a P before every QRS, and it's greater than 100 beats per minute. Sinus bradycardia is a P before every QRS and a rate less than 60 beats per minute. Then there's a regular rhythm. So if you will, if a heart's beating like that, is a regular rhythm. Or there's an irregular rhythm. So it's irregular. And then there can be regularly irregular rhythm. And during your lecture, you had a chance to see where there were 2 beats on the patient, and then it was followed by normal beats, normal sinus beats. So it might have been something like, so know what the P and what the QRS are doing. Remember, from the atria, know the ventricles, what wave is created there. It's going to be important for you. Then let's talk about respiration. Respiration is the process of breathing, where we're bringing oxygen in from the environment to the lungs. They go through the alveoli. You can see that a normal, healthy alveolus has got just hundreds of millions of little tiny balloons, which have a lot of surface area. And then intimately associated with those alveoli are blood vessels. So deoxygenated blood, you can see that coming down to the alveoli, where the gas is going to then diffuse across the alveoli and you're going to breathe it out. And don't forget, that's where we use end-tidal CO2. And then oxygenated blood, the oxygen is going to diffuse into the alveoli, and we're going to then pick up the oxygen, circulate that back to the left side of the heart, and we're going to then perfuse all the organs, every cell in the body. So the deoxygenated blood is coming from the lungs, which is the right side of the heart. So have a picture in your mind's eye of how blood is circulating, what the waves mean, how the lungs and the alveoli function in bringing oxygenated blood to the patient and then taking away waste products. Temperature. Any one of our chemical reactions in the body are going to involve and be best served at normal body temperature. That's why we're at 98.6 degrees Fahrenheit or 37 degrees Celsius. Blood is going to clot best at normal body temperature. If the patient's cold, their heart rate increases, which is stress for the patient. Their respiratory rate will increase, and hopefully it's increased to a point where they're able to oxygenate the tissue and get rid of the gas wastes. Drugs are going to be metabolized and eliminated very slowly because the liver is cold. Blood isn't going to clot well, so wound healing is going to be delayed, and if it's delayed, will then cause wound infection. So we've got to keep the patient warm. Look over this slide where we talk about each of these things if the patient is cold with their heart rate, respiratory rate, drug metabolism, wound healing, and wound infections. My favorite monitor, the first monitor on and the last monitor off, is SpO2, or the pulse ox, or the pulse oximeter as it's called. This was invented through space technology from our astronaut program from NASA. This is where this was developed. So the way this probe works is there's two lights that shine. One of them you can see, and you've looked at a pulse ox before. It's a red light. And then there's the infrared. So it's still a red color, but our eyes cannot detect it. And then the amount of light coming through, the amount of redness coming through, will be detected by the diodes. It's brought by wire up to the electronic processor, where a calculation is made using the Beer-Lambert law we saw in your lecture. And then it will spit out a pulse oximeter wave as well as an oxygen saturation wave. Realize that then, since red light is used, that we're really looking at the redness of the blood. Heme, which is in the red blood cell, can bind up to 4 oxygen molecules. So you can see if it's only binding 1 oxygen molecule, if only one amount of oxygen is there because of what the patient's breathing, that blood is not going to be as red as if there were 4 oxygen molecules, which is the maximum possible on the hemoglobin molecule. Plasma is interesting in that it carries a little bit of oxygen and CO2, and it's a big part of blood. So it's carrying hormones, nutrients, proteins, waste products for excretion, clotting factors. It's going to bring the defense cells against bacteria, viruses, and fungi. It carries water. It maintains the blood vessel shape, blood pressure, and body heat. So it is extremely important for the cells and for our bloodstream to have plasma. It has a lot of functions. Let's identify normal patient vital signs so that we'll be able to recognize when something is abnormal. For adult humans, we're not talking about any pediatric, normal blood pressure is less than 120 systolic over less than 80 diastolic. Normal heartbeat is 60 to 100 beats per minute, so that's normal pulse. Normal respirations are 10 to 20 breaths per minute. And while we're talking about breaths, I want you to make sure that you understand the concept of FRC because it's really important in anesthesia. Remember, FRC is functional residual capacity. So if a person's breathing tidal breaths, that's the VT, the FRC is extra lung capacity that's got oxygen in it if the patient should lose their airway. So it acts like scuba gear so that we've got extra oxygen there. And remember, there's certain things that can mess up FRC, like severe obesity, pregnancy can also mess that up. Normal temperature is 37 degrees Celsius, as we talked about before, or 98.6 degrees Fahrenheit. Normal saturation pulsatile of oxygen, some textbooks will say greater than 92. I sure like greater than 94. And we saw with the oxyhemoglobin dissociation curve how we drop the SAT, that the amount of oxygen that's in the bloodstream drops very rapidly. The PO2 at the bottom of this graph shows you how rapidly it drops. How we went from a SAT of 100 and a PO2 of 100 to a SAT of just 94, and we're at now a PO2 of 70. So make sure you understand that. When we got down into the 86% range, we're in danger. We've got a PO2 of 50, maybe 40%, and it is just not compatible with life when we get that low. At 40, we're in the severe hypoxia range, and the patient's just absolutely not getting enough oxygen to all the cells in their body, and they're in danger, and there could be imminent death for the patient until we get that oxygen saturation up. So 92%, some textbooks, like I said, say I like 94%.